episode of Myeloma Crowd Radio, a show that connects patients with myeloma researchers. I'm your host, Jenny Ahlstrom. We'd like to thank today's episode sponsor, Takeda Oncology, for all they do for myeloma patients. Now, some announcements before we get started. We are well into our Muscles for Myeloma campaign, which is a fitness challenge for myeloma patients. Our ability to handle more difficult treatments gives us longer overall survival, and doctors are determining treatments based on fitness levels. Now, as part of the challenge, we are raising funds for the 2 Myeloma Crowd Research Initiative immunotherapy projects, so you will be getting fit for a good cause. You can join us at a race that we're joining in Chicago tomorrow with Be the Match, and one again in Salt Lake City on the 30th of this month. So these are 2 local 5Ks. You can walk or run and get fit for this good cause. Also, we are hosting day-long patient meetings specifically for high-risk and relapsed or refractory myeloma patients. The first will be held on May 7th in Salt Lake City, and the second will be held June 18th in St. Louis. Several myeloma experts will be there to discuss topics like immunotherapies, high-risk genetics, and effective strategies for relapsed refractory patients, which is what our show is about today. You can check the Myeloma Crowd website and learn more about these live patient meetings, and we will have more meetings to follow in the coming year. Now, on to today's show, and we are waiting for Dr. Siegel to join us by phone, so I'm going to go ahead and give an intro for him. Most myeloma patients will eventually relapse, and so with newer drugs in the myeloma arsenal, what are investigators learning about the right order and combination of treatments to get the optimal responses, especially for relapse refractory patients? And today joining us is Dr. David Siegel. Dr. Siegel is Chief of the Division of Multiple Myeloma at the John Theurer Cancer Center in Hackensack, New Jersey, and has made the facility one of the premier academic centers in the country. Dr. Siegel is also Clinical Professor of Medicine at the New York University Medical Center. Dr. Siegel's research has almost exclusively focused on multiple myeloma and has been published in many leading medical journals, including Nature, the New England Journal of Medicine, Blood, and the Journal of Clinical Oncology. Dr. Siegel serves as the lead investigator of a pivotal multi-center phase 2B study involving 30 cancer centers in North America that led to the FDA fast-track approval of Kyprolis, or carfilzomib, for relapsed multiple myeloma patients. Dr. Siegel is also one of 11 investigators nationwide who brought the chemo agent Velcade to myeloma patients through his clinical trials. Now, Velcade, as you know, is an injectable drug that blocks some of the pathways associated with myeloma growth. Dr. Siegel's studies have shown that Velcade slows and halts progression of myeloma. He's also been involved in many clinical trials using Revlimid and carfilzomib. Dr. Siegel is a member of the MMRC, which is the Multiple Myeloma Research Consortium Steering Committee. The MMRC is a unique research model that was developed to accelerate the development of new and cutting-edge treatments for patients with myeloma by helping collaborate research between industry and academia. Well, we're thrilled that you joined us. Thank you so much for making the time.
Thank you.
Okay, so I have given an intro for you, and we'll just jump right into questions if that's okay with you.
I'd be happy to.
Okay. So one thing that I wanted to ask you about is how you create a myeloma academic center. I don't know where you started out from, but I know that you studied at or worked at UAMS, and then you came to Hackensack and created a myeloma academic center that's really one of the premier academic centers in the country. So in doing this, how do you go about doing that, and how do you create critical mass and myeloma-specific expertise at a new facility?
Well, I don't know that my intention was to do that. I mean, I came from Arkansas to New Jersey. Actually, was hired to start a breast cancer transplant program. But at about the same time that I was hired to do that, people stopped doing bone marrow transplants for breast cancer. So my expertise was always in myeloma, and I just started taking care of myeloma patients, and I think more by word of mouth than by anything. There wasn't a whole lot of activity going on in this part of the country in terms of myeloma, and patients started to come, and we were fairly innovative. At least we tried to be innovative, and we tried to participate in clinical trials. So we had some drugs that other people in this part of the country didn't have at a time when there wasn't a whole lot of alternatives for the management of multiple myeloma. So I think that's what attracted patients. I think, obviously some of it was the interpersonal part of it, and I was fortunate enough to have the opportunity to work with some nurses and administrative people who were not just excellent but amazing and excellent. I think that was part of what made it feasible.
Mm-hmm. And we always suggest that patients go and consult at least with a myeloma specialist, even though they might get treatment locally, because having a myeloma specialist in your corner is really, really critical. So I'm glad people sought you out to do that. I think with the newer treatments, it's more important now than ever. And you have a lot of expertise bringing new drugs to the market. So you have a great perspective on this. You help bring both Velcade and carfilzomib to the clinic in these large-scale clinical trials. So maybe you want to give us a broad overview of your opinion on last year's approvals and your thoughts just generally before we get into details on where myeloma treatment is headed next.
Well, for the recent approvals, obviously, I think we're all very excited in the myeloma world. Although I want to take a step back and say that the first person to be treated with thalidomide was my patient. So I was involved in the development of thalidomide. We were one of the two sites that were most important in developing lenalidomide as well, Revlimid. Actually, every drug that has been approved for myeloma, with the possible exception of Doxil, we've been key participants in their development. Daratumumab, perhaps not key participants, but certainly participants. So I don't want to limit us to Velcade and carfilzomib, but the changes in the myeloma world over the last year have been dramatic. We finally have monoclonal antibodies that are active in myeloma. Daratumumab and elotuzumab have been very important drugs. We were sort of left behind as the breast cancer world and the lymphoma world incorporated monoclonal antibodies into their therapy, and now we finally have effective drugs, and these drugs have activity in situations where we might not have expected to be able to salvage the situation. So I think that this has been very, very important breakthroughs. We have a number of new proteasome inhibitors, ixazomib, Ninlaro, and carfilzomib, I think, are very important. I think that carfilzomib is probably the single most active drug that we have. We have the new IMiDs. So lenalidomide has been followed by pomalidomide, which is clearly the backbone for many therapies, including therapies that are not commercially available at this point. So we've had some very fruitful years, and to the point that I no longer can have conversations with patients. Always one of the first questions that patients ask is, what does the future hold for me? How long do I have? Kind of questions, and we've always been able to at least say this is how myeloma patients do in general. I think for a myeloma patient who walks in the door today, we can no longer say that. I mean, we really don't know what what the timeline is, and that's incredibly exciting. And you said you asked the question about what does the future hold. I think I've always been fairly good at sort of identifying where myeloma was going, what were the new technologies that were going to be the most important ones. And for the first time, that is very, very cloudy, that there is so much stuff going on in oncology in general, but myeloma specifically, that we really can't say that this is clearly the next big area. I mean, I think many of us feel that immunotherapies, but there's so many kinds of immunotherapy that are going on right now that it's almost self-serving to say, well, immunotherapy is where the field is going. That's just too broad of a statement. Which of the immunotherapies, whether it's going to be CAR T cells or combinations based on the monoclonal antibodies or checkpoint inhibitors, so we're very involved in all of those kinds of research. That which of those is going to be the home run? I don't know. They're all going to move the field forward, but which is going to be the true breakthrough intervention? It's nice not knowing exactly, because so many things are attractive.
Well, and the combination potentials are just exploding.
Yeah.
So
no,
that's why I think you really have to have an expert in your corner, because trying to figure out how do you time things and when do you time things and which combination, and then doctors are trying to make it a little more personalized and so many different options.
Yeah, I mean, I hope that.
Yeah.
Yeah.
No, go ahead.
I hope that there are things that we already have in our hands that once we learn to use them a little better, will be potentially curative for patients. We don't necessarily need a huge breakthrough. We just need to identify the right combinations and the right patients to fit those combinations too. And we may be close in some of those patients already.
Mm-hmm. I believe that too. Now, I know that it seems like when you do clinical trials, especially the large-scale trials, they're started with patients who are relapsed and refractory, and then they kind of move maybe to the front line. So in just looking at your papers and things, you have great extensive experience, especially for relapsed refractory patients. So maybe you want to begin by just kind of explaining what is relapsed and refractory, because some patients might not know the difference. And then let's talk about some specifics that you're working on right now.
Okay. So we tend to change the definitions that we use. But it's probably best just to speak in general terms. So refractory means that a patient is not responding to a particular drug. Now, so if you're getting treated with drug X and the disease doesn't respond, you're refractory to that drug. Relapse means that you got treated with a particular drug, you had a response, and now the disease is returning. So that can be either on therapy or off of therapy. So if you had a stem cell transplant 5 years ago and your disease was doing very, very well, and now your disease starts to come back, you are now relapsed. If you are getting treated with a particular drug and your disease progresses while you are on that drug, you are relapsed and refractory. So response followed by relapse off of therapy would be just relapse. Response or lack of response followed by progression on therapy would be relapsed and refractory. And then just refractory by itself means that you are not responding to a drug that is being administered to you.
And then you can be double refractory too. Do you want to explain what that means?
You can be double refractory. You can be triple refractory. Now those definitions get to be a little bit confusing. So the term double refractory was I guess coined mostly to mean that a patient had become refractory to both Velcade and Revlimid, and so that became a key point, because when Velcade and Revlimid were the two best drugs that we had, the likelihood of responding and being able to maintain a response once you became refractory to those two drugs was very, very low. But you could also be refractory to those two drugs in combination. So you could be double refractory, but double refractory to the combination was even more ominous than being refractory to those two drugs independently. Well, now we have many more than two drugs that are important, so we start to use the term quadruply refractory, because we have Revlimid and Velcade, pomalidomide and carfilzomib as the dominant drugs. So not just in terms of conversation, but even in terms of the FDA wants to know who is not responding to those four major drugs. So we now have daratumumab. We're going to talk about patients being fivefold refractory, and we're going to have arguments about whether a patient who is refractory to carfilzomib should be considered proteasome inhibitor refractory, or do you have to show refractoriness to both Velcade and carfilzomib before you are considered proteasome inhibitor refractory? So this gets to be very, very complicated language as we have more and more drugs that are effective.
And then sometimes using them in combination will bring it back into action, or you might be refractory, but you add something to it, and then it works all of a sudden.
Yeah, you can have patients who are independently refractory to steroids, to pomalidomide, and to carfilzomib, and you put those three drugs together, and you get excellent responses, and sometimes those responses can be quite durable.
Well, let's start broad and then go down to some specifics. What current strategies do you see as being particularly effective for relapsed refractory patients?
Well, I don't know that there is first off, relapsed refractory can mean so many different things, and relapsed refractory can be to your first try at very early drugs, and that is obviously a completely different meaning than somebody who has seen 6 or 7 drugs and multiple drug combinations. So the early relapse is something that we have now come to expect the patient not only to respond, but to respond well and durably. So this is a completely different world than it was 5 years ago. I think the relapsed refractory that is problematic is the patient who has seen most of those major drugs. Now, we are fortunate that we have had daratumumab become available. We have panobinostat, we have varinostat, we have a whole series of monoclonal antibodies. Elotuzumab is commercially available. Pembrolizumab, which is one of the checkpoint inhibitors, is in clinical trials. But the point being that we have a bunch of new drugs or drugs that are coming along that almost no patients have seen. So we are fortunate at this particular moment to have commercially available choices. Beyond that, centers such as ours that have large numbers of clinical trials going on, we even have reasonable drugs for those patients who have become refractory, even to the newest of drugs that have been approved. So I think it is a very exciting time not just for those of us who care for patients with myeloma, but those of us who have myeloma or care about patients with myeloma. So I think we have to be cognizant of what is available out there, and that's part of why it's so important to have somebody who has particular expertise in myeloma as part of your care team, because otherwise you lose the opportunity to participate in clinical trials with new drugs, or even to consider combinations that your local doctor might not be aware.
Right, I completely agree, and I think I heard that at ASH a lot. That some of the myeloma specialists were saying, it's going to take us some time to figure out what you said earlier, who these combos are best for, when to use them, when to reserve them, and when to use them most effectively and for whom. And I really can't stress that enough. I think myeloma is complex enough that, and now with a lot of the new treatment options, which is a great problem to have, right? You have more options.
Yeah.
And so it might be a little confusing using them, but you have more. It's a great blessing. So you really need somebody in your corner. And I want patients to understand that there are a lot of patients, many, many patients who do this. They go to an academic center. They get kind of a care plan crafted by a myeloma specialist. They go back to their local center and then have that plan implemented. And then as they get checked, and they can do periodic checks with that myeloma specialist so they're up to date on their care or where they're at. And that's very common in myeloma. So I want patients to know that
needs to be more
possible.
common. It needs to be more common.
It needs to be more common. I think so too, because I think there are a large majority of patients that just go to their local oncologist, and my guess is that they're 2 to 3 years behind all the published work. And we've had other doctors say, every 2 years we would have the international meeting, which would be okay, but now everything's happening in 6-month increments or faster. So that's not really sufficient anymore.
And I think that, and this is not a criticism of your local oncologist, 60% of the work that they do is breast cancer, and local oncologists need to be expert in the diseases that they see most frequently. And after breast cancer comes a whole bunch of other diseases well before you get to myeloma, just in terms of the numbers of patients. So it's even the best of local oncologists can't keep up with the details of diseases that are much more narrowly affecting the population. So this is I think something that every myeloma patient should be aware that it's very, very hard to be an expert in everything.
Right. And just as an example, I went in to go get checked at my very first appointment, and my doctor, the local oncologist, I asked him how many myeloma patients he saw, and he said 5. And then I went to an academic center that was still in my city, and they had over 300, closer to 400. So the difference in being able to treat those and see patterns, you're able to see a lot of things that they will never see. And you understand the science and the art of it. So I highly suggest that patients do that. If you had to estimate how many patients in myeloma are seen by a local oncologist versus a specialist, what would be your guess? I know it's hard to say, but I'm just kind of curious.
You said something about the number of patients. We, between my colleagues here in Hackensack and myself, we're seeing 200 to 300 consults a year. I think an extraordinarily busy local oncologist might see 2 or 3 myeloma patients a year. To give a guess as to how many patients in the United States have a quote unquote myeloma specialist involved in their care, I would guess it's 50% of them, maybe even less than that. It's just geographically it's impossible for some people, and that's why people such as yourself and some of the patient advocacy groups are so important, and why patients should take the opportunity to listen when information is made available by you, or when one of these patient directed seminars comes to their neighborhood. It's an important thing, and sometimes patients have to force their local oncologist to pay attention to some of the newer information, just because it's impossible for them to keep up with a disease where they only have one patient.
Right. Well, you don't want to be having them go back to Google things while they're taking care of you. So, and I think they have to do that sometimes because they're just overwhelmed by, breast cancer, prostate, lung, or whatever else they're treating.
Yeah, they need to have their myeloma expert that they can call and say, I just saw a patient who has this, and this going on. What do you think?
Mm-hmm. Yeah. Now, let's talk about some specifics. You talked earlier a little bit about pomalidomide, and there's thalidomide and lenalidomide and pomalidomide. When you're looking at relapsed refractory, how do you use pomalidomide, and when do you choose to use it, and how do you incorporate it into treatment for these patients?
Well, I think pomalidomide is an exciting drug. It has certainly advantages and disadvantages. One of the and by far the most important advantage of it is that it's the most potent of the IMiD drugs, between thalidomide, lenalidomide, and pomalidomide. The way that it was approved by the FDA, it can't be used very early on. It's only reserved for patients who have relapsed disease or relapsed refractory disease. And but as I said, the most potent, the most active patients whose disease has progressed on Revlimid will still respond to pomalidomide. Pomalidomide has allowed us to do a lot of things. It's easy to use because it's not excreted through the kidney. So for all those myeloma patients that have poor kidney function and whom we have to worry about the dose of lenalidomide, that's not a worry with pomalidomide. So not only is it more active, but we can use it easily in situations where we can't necessarily use lenalidomide with as much freedom. So I think it adds both response and flexibility, and that I think is particularly important when inexperienced people are using the drug. So when local oncologist is trying to put together a combination, there might be a little bit less trepidation in using pomalidomide. But I think pomalidomide has extended the use of many drugs. So we have patients whose disease has progressed despite being on multi-drug combinations, and when we include pomalidomide in those combinations, sometimes we're able to salvage responses that are quite durable. So it has been an exceptionally exciting drug, and it works in combinations with the same degree of ease that lenalidomide does. So I think people who have acquired experience with lenalidomide will find very similar experiences with pomalidomide, and so it's not as perhaps scary for either the patient or the practitioner because of those similarities to lenalidomide.
Mm-hmm. And if somebody has kidney failure right out the get-go when they're diagnosed, when will something like pomalidomide be available? If it's only available now for relapsed refractory patients or approved that way, how long does it take to get approved for an earlier state?
I don't know that it will ever get approved for the frontline patient in myeloma. As far as I know, there are no clinical trials going on with that. I think that there are perhaps even newer drugs in development that may supplant pomalidomide in that regard. But the way that the drug is approved right now, there is no opportunity to use it in the newly diagnosed patient. Doesn't mean that it can't be used very early on for that patient who gets a combination as part of their initial therapy that doesn't work, to move on to a pomalidomide-based regimen fairly quickly is certainly reasonable. But the way that the guidelines are written is that patient has to have seen thalidomide has to have seen lenalidomide previously.
Mm-hmm. Now, let's move on a little bit, because I know you're doing a clinical trial with vorinostat, which is an HDAC inhibitor. So maybe you want to explain what that trial is all about and why vorinostat over, I think it's panobinostat, is it? That's another HDAC inhibitor?
Well, yeah, I apologize. So vorinostat, I wouldn't say over panobinostat. So vorinostat has been around longer. It was approved for the treatment of cutaneous T-cell lymphomas. It was never approved for the treatment of myeloma. And yet we had developed a lot of experience, and it's a very, very effective drug, and used in the right circumstances can sort of resensitize a patient to drugs that they had seen previously. So these histone deacetylase inhibitors, I'll talk about vorinostat first and then panobinostat second. These histone deacetylase inhibitors have no activity by themselves. The patients do not respond to the single agent. Yet we can take a patient who had been getting Revlimid but had progressed on the Revlimid and add the vorinostat, and all of a sudden the patient responds again, and sometimes those responses can be quite durable. Merck never managed to get vorinostat approved for the treatment of myeloma, although it does now have NCCN guideline-based approval. So while the drug can't be advertised in myeloma, it is sometimes possible to get the drug approved. Well, fortunately, Novartis got a very similar drug called panobinostat approved. It was approved in a very specific circumstance, but again, panobinostat, very similarly to vorinostat, can be combined with a number of drugs, and the response reacquired. So I think these histone deacetylase inhibitors are very important drugs, and there are patients in whom you would project that nothing was going to work, and we use these combinations, including a histone deacetylase inhibitor, and lo and behold, we see responses that are both surprising but well maintained, and these are drugs that, when used carefully and in the right circumstances and combinations, can be very well tolerated. So I think it's very exciting, and there are other histone deacetylase inhibitors being explored both preclinically and in early clinical trials. So I think we have reason to be hopeful that this class of drugs will continue to be part of our armamentarium. But panobinostat is approved in myeloma, and I think is a very effective drug when used in the right combinations at the right times, and that's part of the feel that one needs to get.
Mm-hmm. And do you want to talk a little bit about your clinical trial that is using vorinostat?
So we have had a number of clinical trials. The one that we're actually just putting the manuscript together now, we took a bunch of patients in whom the drug Revlimid had either not worked or had worked and then failed, and took those patients, many of them directly, progressing on Revlimid and dexamethasone, or Revlimid and dexamethasone in combination with other drugs, and went directly to add vorinostat, and these patients again responded. So the data was actually, for us, very exciting. Response rates that were in the 20 to 25% range in a population in whom you would have certainly not expected that to be the case. We also had a clinical trial we called our quad trial, in which we used the combination of carfilzomib, lenalidomide, the vorinostat, and dexamethasone, so a 4-drug combination. And this was actually extremely well tolerated, and the response rates were quite robust. And I think while the response rates were certainly much higher in that clinical trial, I think the other clinical trial that I had just spoken of was perhaps more exciting because it proved a scientific point. I think more so than our quad trial, because it took patients that were failed. The patients weren't failed, the drugs were failed, and by adding the vorinostat, we were able to resensitize them to these therapies that were no longer effective or had never been effective. So I think as a class of drugs, very, very exciting. And now we have panobinostat, which is more available, and we now use sort of interchangeably in those circumstances that we had learned from our quad trial and from our vorinostat salvage trial. So I think that the data was impressive, and now we have the opportunity to expand on that.
Well, it's a huge blessing. It's like a make it work again strategy.
Yeah,
to bring possibilities back to patients.
Yeah, and I think it hopefully will teach us something about how these drugs that are so important to us stop working and why they stop working, and if we can understand what it is about the histone deacetylase inhibitor that resensitizes patients, it may give us opportunities to develop new drugs or new strategies that can be effective in even more patients.
Mm-hmm. And when you're looking at that, some of the reasons why these drugs stop working, do you think it's because the clone is changing? Because I know the clone can evolve over time and then it stops working, and this does something. I don't know if this, affects the clone, but maybe it just, I don't know.
Yeah, so we have this notion of clonal tides in which there are multiple populations in the myeloma that we select for, and we select for a clone that is resistant to one drug, and then we switch drugs, and we then select for clone for we're then able to kill that clone that had become dominant, but now a new clone evolves. So what I think is particularly exciting about the work that we did with vorinostat was that wasn't the case. We took a patient who was clearly resistant to Revlimid. So the clone that was the dominant one was resistant, and we add the vorinostat, and all of a sudden that clone becomes sensitive again. So the notion that it is a tide back and forth of different subpopulations of the disease that explains this clearly isn't the case here. I think that makes it even more exciting.
Yeah, that's very good information. Amazing. Well, I think I want to come back to this 4-drug combination idea in a minute, but I do want to talk a little bit about what you were talking about earlier and people becoming refractory to drugs and then trying different combinations. So let's say somebody becomes refractory to a Velcade. Is a proteasome inhibitor, you mentioned carfilzomib, still an effective option? Can you swap these things out and have them still work?
Absolutely. I think that's the exciting part about these drugs is even drugs that hit the same targets can be effective in patients who have become resistant to that target. What is the explanation? I mean, part of it is just that you can get higher concentrations of a drug, and therefore it overcomes some level of resistance. But part of it is well beyond that, and I think that we need to be cognizant of the fact that all proteasome inhibitors are not created equal, all IMiDs are not created equal, and that the notion that we have to switch classes and we have to jump to other strategies isn't always the case. I mean, we're lucky that we have the opportunity to do that now. We have more categories, so the ability to transition from one category to another is now much easier for us. But the fact that one becomes refractory to Velcade doesn't prove that one is going to be refractory to Kyprolis or carfilzomib.
Mm-hmm. Well, that's important for patients to know. And I know about ixazomib, which is a new oral proteasome inhibitor. Can it be used in the same way? Like if patients are refractory to Velcade or carfilzomib, can they use that instead? But because what you're saying is all proteasome inhibitors aren't the same.
No. Yeah. So structurally, ixazomib, Ninlaro, is very, very similar to Velcade, to bortezomib. Mm-hmm. But we know that patients who are refractory to bortezomib can respond to ixazomib, to Ninlaro. We have less information about being refractory to carfilzomib and then responding to Ninlaro, but we have certainly seen patients who have failed carfilzomib-based combinations who have responded to Ninlaro-based combinations. So it's very confusing, but pleasantly confusing field, and whether it's just that it's a slightly different combination or that the mechanisms of resistance are different enough to allow for continued responses, I think we still need to figure out some of that stuff.
Mm-hmm. Now, you were talking about combinations, and the HDAC inhibitors are a perfect example of bringing people back to getting it to work. Are there other combinations that can overcome, let's say, being refractory to a single agent, like either a proteasome inhibitor or a IMiD?
Yeah, I think that we see that all the time. And back in 1997, when we treated the very first patient with thalidomide, we started off using it as a single agent, and we were amazed. It was perhaps the most important pharmacological breakthrough in myeloma, and all of the patients who got put on thalidomide were refractory to corticosteroids, but we added corticosteroids to thalidomide, and lo and behold, the patient started to respond again, and sometimes those responses were very, very deep and very, very durable. And I think that was sort of a revelation for me, but it is something that everybody needs to be aware with almost all of these drugs that we use. The fact that Velcade failed us the first time around doesn't mean that Velcade is going to fail us in the next combination or the third combination. And we see that not just with Velcade, but with corticosteroids and IMiDs. And the fact that we fail once doesn't mean that drug is crossed off the list. And I think that is perhaps the most important principle to understand, is that is to be enough respectful of our inability to understand why these things happen, that we need to be very, very comprehensive in terms of understanding how many different ways we can use these drugs. And if we use carfilzomib once and it doesn't work as carfilzomib and dexamethasone, that it may very well work as carfilzomib, Revlimid, and dexamethasone, or carfilzomib, pomalidomide, and dexamethasone, even though the patient had gotten Revlimid before and failed, or pomalidomide before and failed, that these combinations still need to be explored, because we will get good responses over and over again, even though it's the same drugs.
Mm-hmm. So what you're saying is be flexible and maybe don't take no for an answer when something's not working.
Don't acknowledge that the disease has won, because it hasn't. And as we add more drugs, those algorithms become so much more complex. When you had 2 drugs, there was really, you could use thalidomide by itself, you could use dexamethasone by itself, or you could use thalidomide and dexamethasone. Once you add, dexamethasone, Revlimid, and Velcade, the number of combinations becomes exponentially greater. And when you have 10 drugs the way that we do now, the number of combinations becomes almost infinite. And I'm not saying that every patient needs to get all 100 potential combinations. That's clearly not the case. But there are so many combinations that we should be very, very leery of giving up too early.
Mm-hmm. Yeah, I agree. Now let's go back to the 4-drug combination idea. I know that typically, these combinations have to be tested in clinical trials, as you've run. And how long until? How do you do this rapidly? I mean, we have so many different combinations. How do you do some, rapid-fire clinical trials to get to these conclusions faster, in your opinion?
Well, first off, in the United States, and this is perhaps not true in most of the rest of the world, it's not 100% true that you have to have a clinical trial that proves the exact thing that you are trying at that moment. In the United States, we use drugs off-label all the time, and so the need to have a large clinical trial that proves that a particular combination is justified is not always the case. And now, don't misunderstand what I'm saying. I think we need to do clinical trials to establish the safety and role of different drugs. But I think the individual institution needs to say, okay, this is a combination worth trying, and then do the pilot study and publish the data from that pilot study to show that a combination is effective in a particular population and can be done safely. And we've tried to become very, very centralized in how we do clinical trials, but when we do that and we only do large trials, we miss out on the opportunity for the smaller combination to be tested quickly. And I think we need to make sure that we have the interest and the liberty to do those kinds of trials. The problem is that very often these drugs are in the hands of the pharmaceutical companies, and it requires the cooperation and collaboration between a number of companies that each own the individual drugs. I think we're very fortunate in the myeloma world that there are a number of drug companies that are willing to do that. I mean, Celgene with its series of IMiDs has been very, very happy to say, yeah, you get Amgen to do to provide the carfilzomib or whatever the next new drug is, and we will be supportive of a clinical trial using our drug as well. So it's a difficult environment sometimes, but I think we've managed to do most of the things that we need to do.
Mm-hmm. Well, wonderful. So I know we're running out of time. I am going to keep you over if that's okay with you, because I have
I have a
a
patient
few other
waiting, but
questions.
I'm glad to talk.
Oh, you do? Okay. We won't make them take too long. Now you are doing a clinical trial using a glutaminase inhibitor,
Glutaminase
DB839. Okay,
inhibitor.
glutaminase. Okay, so can you explain what this is and how it's used? I want you to be able to cover that.
Well, I don't know that we should spend an enormous amount of time on it because I'm not sure that that's a drug that is going to be a breakthrough drug in myeloma. But I think that that field in general of what we call metabolomics, so we tend to think that there are sort of individual pathways that are critically important in a particular disease. But one of the things that's funny about cancer, we think that they are, cancer cells are big bullies and are impervious to things. But part of what it is to be a cancer is that a lot of your physiology becomes very, very delicate. And these cells aren't as smooth running as the normal cells in our body. So things that are sort of general physiology, the sort of normal background processes that go on in cells, sometimes make the myeloma cell, but cancer cells in general, more susceptible to these kinds of disturbances than you might expect. You would instinctively say, no, the cancer cell is much tougher than the normal cell. But in fact, that's not the case. So these cells these drugs that interfere with the kind of metabolism that is normal metabolism, sometimes kill the cancer cells much more easily than they kill normal cells. So metabolomics, I think, is an important area of investigation, and there's lots of drugs and lots of kinds of areas out there that need to be explored, and we are not quite at the point of being able to say, well, this is clearly a drug that is going to work in myeloma, and we're still, to some extent, at the trial and error stage in terms of the kind of clinical trials that we do.
Yeah. My last question will be, and then we'll move to caller questions, is I know there was a newly updated NCCN guidelines for the treatment of multiple myeloma, and there was also a recent International Myeloma Working Group paper on high-risk disease. So what stands out to you from these two things, and what are issues patients need to think about as they relapse, like when trial or how to best keep their options open, things like that?
Well, I think that the NCCN guidelines are very important, not as an absolute blueprint for everything that is available, but particularly oncologists who don't do a lot of myeloma care as part of their practice, they tend to say, well, this drug is approved in this situation. But the NCCN guidelines will very often have combinations that aren't on label, that can justify the health insurers' participation in supporting a strategy. So the example that I will use is that the NCCN guidelines have what is called a 2A designation for the combination of carfilzomib, Revlimid, and dexamethasone in a newly diagnosed myeloma patient. Well, if you looked at the package insert, that doesn't exist. But if you had a patient who, for instance, you didn't feel that Velcade was an appropriate drug for that newly diagnosed patient because they had horrible pre-existing peripheral neuropathy, as an example. Well, you could use carfilzomib in that patient based on the NCCN guidelines. And I think the overwhelming majority of practitioners out there have no idea that that's the case. So having those guidelines in front of you can sometimes allow you to do things that are right for a particular patient that you might not normally understand is available.
Mm-hmm. You may have not thought about it like that before.
Yeah. So you have that diabetic patient who comes in with horrible pre-existing peripheral neuropathy. Well, you know what? You have a good choice that if you just look at the NCCN guidelines, you might not otherwise know. And that could be true for any number of combinations. The spectrum of choices is not just what the FDA has approved. And in terms of the position paper on high-risk myeloma, obviously we've done pretty well, not well enough, but pretty well in patients with standard risk disease, and I fully expect those patients to live not years but decades. But the high-risk patient, that unfortunately is not the case. And I think the most important point that position paper makes is that we need to do clinical trials that allow us to understand what works in high-risk patients. And it's not so much a roadmap as to how to treat a high-risk myeloma patient, but more to give a notion as to what is available and how important it is to have those kinds of patients participate in clinical trials, so that we actually can expose those patients to newer therapies and hopefully intelligently thought out therapies, but also to allow us to learn so that the next generation of high-risk patients can be treated in a more sophisticated fashion. We all have sort of our bias about what we should do in a high-risk patient. For instance, here at Hackensack, young high-risk patients, we do allogeneic transplants in a lot of them. But if we don't do it in the context of a clinical trial, then it almost doesn't matter that we look at our patients and say, wow, look how amazing our high-risk patients who have been allotransplanted are doing, because we haven't done it in the right fashion so that we can transmit that data to our colleagues. So I think that's the most important take-home message from the position paper, is to say, let's do our work carefully so that when we think we learn things, we actually have learned them, and that we have learned them in a context that is supportable and that we can transmit to our colleagues and to the patient,
you have proof.
most importantly.
Yeah. Even if you do a retrospective study, at least you have the data to back it up.
Yeah, and we all talk amongst ourselves. Oh, I think we should do this, and I think we should do that. Well, at some level, that's irresponsible if we don't gather information in a way that moves the field forward.
That's very, very helpful. Well, I want to open it up for just a few caller questions. I know you have to go quickly, so we won't take a lot of time on it. But if you have a question for Dr. Siegel, please call 347-637-2631 and press 1 on your keypad. And we will start with you, Eric.
Thanks very much. I just had one question. Have you and your colleagues at your center, doctor, have you pretty well moved away from the idea of second and third transplants now that we have all these new drug combinations? I know a lot of people are still wondering if they should get another autologous transplant after relapse to reset their disease.
I mean, I think that has to be an individualized answer. I think that right now we sort of put transplant in a separate category, and I don't think that we should. If we had a patient who had a great response to a carfilzomib-based regimen and then for whatever reason stopped therapy and the patient stayed in remission for a year, for 2 years, for 3 years, and then relapsed, we'd say, wow, that patient had a great response to carfilzomib. Let's use a carfilzomib-based regimen again. Well, why do we place a transplant in a different category? If I have a patient that, in fact, we have a patient who's coming up on her 20th anniversary of her stem cell transplant. If I had a patient who had a 10-year remission after a transplant and now is relapsing for the first time, well, the first thing that's going to come to my mind is a transplant. If I had a patient who had a 10-month remission after a transplant, probably the last thing that would come to my mind would be a stem cell transplant. But transplants are, number one, very effective, and when we have a patient in whom it has been effective, we should certainly be thinking about it again. Transplants have very, very little in the way of long-term toxicities, whereas almost all the other drugs that we use have cumulative toxicities, and in an environment where the cost of care is of greater and greater concern, transplants are one of the cheapest things that we do. So I don't think we're ready to cross transplants off the list yet.
Thank you very much.
Okay, thank you so much for your question. Okay, our second caller at 949-5572. Go ahead with your question.
Hey, Dr. Siegel, thank you for being very generous with your time this morning.
My pleasure.
Very helpful and very hopeful, especially in the area of high risk. It seems that all patients eventually become high risk, and this information sharing about between doctors and strategies seems to be an important component to increase the pulse of learning. A couple questions. It's amazing what has happened in the field of myeloma over the past few years. What do you think are the factors that cause the explosion of the development of myeloma?
I think a big part of it is just luck that we managed to have enough drugs being tested at one time that we hit a couple of home runs. But I think that the myeloma community, and I think this is patients as much as physicians, has become extraordinarily well organized. That myeloma patients communicate incredibly quickly with one another and with the healthcare providers that they have, and the myeloma patients' willingness to participate in clinical trials has made it a very exciting area for the pharmaceutical industry to come to, and I think it's as much a credit to groups like the MMRF that have organized patients and made myeloma attractive to the pharmaceutical industry that is responsible for this as much as anything. A decade ago, we had to beg the pharmaceutical industry to let us have their drugs, and now they're like banging down the door saying, please, will you do our clinical trial?
Yeah, there has been an explosion of patient community with IMF and MMRF and now the myeloma crowd that have created a rated community that have taken on different niches to support research and patient involvement. And so that's interesting. That has played an interesting role in it. And I appreciate all the work that the myeloma crowd's doing. But looking forward to your interview.
I mean, I think that this is exactly why we've had the success that we have had, is because my myeloma patients become aware that stuff is going on faster than anybody, and this is because it's such a close-knit community.
All right. Well, thank you for your time this morning. That's all I have.
Okay, thank you so much. And we have actually one more caller. So 847-5748, and I'll just ask you to keep your question quick.
Yeah, thank you. Thank you, Dr. Siegel. Is there any evidence that 4 drug combinations are more efficient than 3 drug combinations. And you mentioned how many permutations there are in choosing those 4 drugs. Is there any way to know a priori which are more likely to succeed, either by genome profiling or any other type of before the treatment assessment of the patient?
That's an extraordinarily good, astute question. Unfortunately, not one that I really have a good answer to. So when we say 4 drug combinations, it's almost a meaningless term. It's the right 4 drug combination, exactly as you were implying. And there are 3 drug combinations that are better than 4 drug combinations. It's just a matter of which drugs and which patient. So we are at the verge of understanding what drugs are going to be best for what patients. But this is really in its infancy, and we can't even do that well for single drugs. There are certain profiles that we think a patient is more likely to respond to Velcade or less likely to respond to Velcade. But even talking about a single drug like that, you would never not give a patient Velcade because they don't quite fit the profile, and you would never choose to not move on to another drug quickly because a profile seemed to imply that Velcade was the best drug. So unfortunately, we're still much more at the empiric stage than the informed stage, and that's when we talk about single drugs, in terms of having tools that will say, okay, this is the best 4 drug combination for this particular patient. No, we're not there. I will tell you that here at Hackensack we have a group. We have a close relationship with a big bioengineering group, and one of the scientists who works with us has developed a 3-dimensional device that can propagate primary myeloma tissues. Well, one of the interesting uses for that is going to be to take a patient's myeloma cells, put them in the device, and see what can kill them. At the most basic level, that's a way to answer the kind of question that you're asking. But yeah, I hope one day gene expression profiling, whole genome sequencing, epigenetic analysis of tumor cells will allow us to have a really quick, easy answer to that. But I still think we're certainly years and perhaps even longer than that away from being able to virtually test drugs.
Right. Thank you.
Welcome.
Okay, thank you so much. Excellent question. Dr. Siegel, we are so grateful that you joined us today. We're going to let you get back to your patients, but this has just been an outstanding show. We're so thankful for your work, that you work every day on behalf of us as myeloma patients, and we're just so thankful for all you do, and the show has been extremely hopeful with some great takeaway messages.
Well, I had fun. I like talking about myeloma, and I apologize for all the telephone difficulties. And if you invite me again, I promise to be there on time and not to drop the phone call.
Oh no, it's absolutely fine, and we'll make it all perfect after the fact. So you're good.
All right, I appreciate it.
Thank you so much. Appreciate it.
Thank you so much.
Thank you for listening to another episode of Myeloma Crowd Radio. Join us for future shows to learn more about the latest in myeloma research and what it means for you.
Judy was boring.
Hello.
Then Judy discovered ChumbaCasino.com.
It's my little escape.
Now Judy's the life of the party.
Oh, baby, mama's bringing home the bacon.
Whoa, take it easy, Judy. The Chumba life is for everybody. So go to ChumbaCasino.com and play over 100 casino-style games. Join today and play for free for your chance to redeem some serious prizes. ChumbaCasino.com. No purchase necessary. Void where prohibited by law. 18+ terms and conditions apply. See website for details.